I will be doing a critical appraisal of a guideline, and I would like to start with a case scenario first. This is a 62-year-old gentleman who is a known diabetic for 10 years who presented to the emergency with fever for 3 days, dysuria and confusion. On examination, had a blood pressure of 80/60 and right renal angle tenderness. An EBG done in casualty showed metabolic acidosis with a high lactates. Clinical diagnosis of a septic shock secondary to probable urosepsis was made, and they started rushing fluids, started him on broad spectrum antibiotics, and an noradrenaline infusion was started. Now our question here is, will this patient benefit from receiving IV steroids? And I will be critically appraising this guideline recommended by the BMJ rapid recommendation on corticosteroid therapy for sepsis, which was published in 2018. And I will be using the JAMA Users Guide for Medical Literature to do this critical appraisal, and I will mention a little bit about Agree2 at the end on how to use it. So before starting, I would like to note a difference between using a systematic review and using a guideline. A systematic review will look at multiple levels of evidence and give you the probable effect at the end of the day. It doesn't tell you whether to use it or what the recommendation is. In a guideline, people are looking at already given evidence like a systematic review, and from different perspectives are giving their opinion on it. So at the end of the day, we should know that it's an opinion and we should use it accordingly. There are certain conditions where we may not have evidence, or for instance in pregnancy where appropriate amount of studies are not there, the best quality will be an expert's opinion. So those type of situations, or in COVID when suddenly there was a spike of this thing, nobody knew what to do. So there we may, these are very useful. Okay, so when according to the JAMA Users Guide, when we are going through the guideline critical appraisal, there are 6 questions that we are broadly asking. Like Sir said in the beginning, the stages of we are actually looking at each of those stages separately. So the first question is whether the question was clear and comprehensive. Then we look at whether the recommendation is based on best current evidence. Then whether whose point of view is this particular guideline from, and whether that is in accordance to what we want out of the guideline. The next, whether the authors have given a strength for the recommendation, like Sir said, we use the grade tool, and whether it is easily understandable for people, and whether there were any conflicts of interest. So coming to the first question, is the clinical question clear and comprehensive? For this study, I felt that the clinical question was clear and comprehensive. Under this, we look at 3 things: whether the intervention was clear, whether the alternative to the intervention was clear, and whether all the relevant outcomes were considered. So in this study, the clinical question that they asked was, do corticosteroids reduce death or improve recovery in people with sepsis or shock? So the population was defined as patients with sepsis or patients in septic shock. Intervention were corticosteroids, and alternative was no corticosteroids. For the outcome, they had an international panel with members of patients who had sepsis and survived, caregivers, intensivists, internists, nurses, endocrinologists, physiotherapists, trialists and methodologists, and they pre-decided a set of outcomes that they felt was important to the patient. So the outcomes for this particular guideline that they looked at were mortality, neuromuscular weakness, quality of life, post steroids or post sepsis stroke and MI, length of ICU stay, length of hospital stay, hypernatremia and hyperglycemia, which are complications of corticosteroids, and whether there was any super infection. Coming to the next question, was the recommendation based on the best current evidence? So prior to the publication of this guideline, there were these were the guidelines that were recommending treatment for or against steroids in sepsis or septic shock. All of them had recommended against steroids in sepsis, and all of them had been in favor to give in conditions with shock. So this was the evidence available prior to doing the guideline. So after the last guideline was published in the previous page, 2 new trials had come out. One which studied 3,658 patients and mortality at 90 days did not find any difference in mortality. And the second trial which came out had looked at 1,241 patients and found that it reduced 90-day mortality. So there was some conflict in the available evidence, and these two were in addition to previous known evidence. So the panel decided that they wanted to do a new systematic review, and they appointed a separate committee for it. Few panel members were same for both the systematic review and the panel that formulated the guideline, and they looked at the pre-decided outcomes. So they decided to update a pre-existing systematic review, which was a 2015 Cochrane review on the same topic. They did a comprehensive search of the available databases, and no language restriction was used. And they even used conference proceedings and abstracts from the period. So they took studies from 3 months prior to the previous systematic review till 2017. The systematic review was well done. The screening was done by two separate doctors, and any disagreement was adjudicated by a third person. And data extraction also was done separately. They also looked at the risk of bias and attributed the risk of bias at the end of the systematic review. So the 2015 Cochrane review had identified 30 studies. So from 2014 to 2018, they got 12 new studies, and all 42 were included in the new systematic review. So 42 number of trials with 10,194 patients were included in the systematic review. So these were the outcomes that they had pre-decided that they wanted to look at, and except for quality of life, for which they did not find any data, they were able to, using this current systematic review, get to an answer. So our values and preferences, coming to the next question, our values and preferences appropriately specified for each outcome. So like I said, at the end of the day, the guideline is an opinion of a panel of people. So if the perspective of the panel of people is in a certain way, they may come to a different conclusion from the said evidence as opposed to something else. For instance, monitoring glucose continuously in the ward may provide better outcomes in a patient who is admitted with sepsis. But that might not be very practical for a nurse to do. So where all different people's perspectives also were included is a question we have to ask. Ideally, if we can get the patient's values and preferences, that would be the best way to proceed. But such evidence is rare. In its absence, sometimes we can use the experience of clinicians who have clinically made these decisions along with patients and patient caregivers. So in this particular guideline, they had predetermined the patients, because patients are sepsis survivors were part of the panel. They had asked them what they would feel, whether how they would feel about gaining some mortality with gaining some weakness also, what their perspectives were. For mortality, patient opinions and clinician experiences were mentioned separately, and both of them preferred trading of a slightly improved mortality for some morbidity. For the other outcomes, they primarily relied on what the clinician experience was. Do the authors indicate the strength of their recommendation? So for this, I'll briefly give an outline of what the grade recommendations are. It is a tool to report your strength of evidence. So it can be very low, moderate or high at the end of the process. And based on that, it's a standardized way of saying how confident you are with the evidence that is present. So initially we establish a level of confidence based on what the type of study is. If it is predominantly randomized trials, we start off with a high confidence. And if it was observational studies, we start off with a low confidence. In the second stage, there are things that increase your confidence or decrease your confidence. So the things that decrease your confidence are if there is a high risk of bias, if there is a lot of inconsistency, if the data is indirect, if it's imprecise, and if there is evidence of a publication bias. And we improve our confidence if the effect size is large, if there is a clear dose response in the effect, and when you account for the confounding factor for whether it would have accounted for the reduced effect. So sometimes when we look at baseline characteristics, we may find that one group is, let's say the treatment group is worse. So we can say that if the confounders were not there, maybe this would have showed a better testing. So ideally your confidence in the grade approach goes up in that situation. At the end of the day, this is how the grade is reported, and most studies we can see these either 4 pluses or 4 stars, and that will tell you how confident we should be or how confident those particular reviewers were in the evidence that is available. Now, if the grade is strongly against, we'll just look at this above table alone. That means do not offer the intervention. You can be fairly confident that this is either harmful or not going to be beneficial. And if it is strongly in favor, we should, like Sir said for aspirin in MI, we should offer the testing. But there are a lot of things that come in the weak against or weak in favor, where it has to be an individualized decision, mostly after discussion with the patient and the caregiver. So in this particular study, they had given a weak recommendation to give corticosteroids. And the evidence was, the grade was given here, and the quality of the evidence was low, or the confidence in the quality of evidence was low.
What about mortality? Can you tell how can you interpret that mortality in that figure?
So the 18 fewer people died in the arm with steroids as compared to people who did not receive the steroids.
18 fewer per 100 or?
4,000.
So that's important. So when you tell somebody what is the final evidence, should I give a septic shock patient steroid? If you give steroids, 18 per 1,000 less will die. But the confidence in that evidence is
very low.
So what is the final recommendation? Is weak recommendation. Now let's keep that. So weak recommendation to give steroids. What about for weakness?
So 53 per 1,000 people had less weakness in the group that did not receive steroids.
Or you can say that there will be, if you don't give steroid, you can avoid some weakness. Or in other words, steroids will cause some weakness. It's a harmful outcome. So it is less than the people who don't have steroids. Length of ICU stay?
And hospital stay was shorter by 0.7 days.
So 1 day less hospital stay. Okay.
So is the evidence supporting the recommendation easily understood? Here, okay, the purpose behind the strong recommendation is whether to just take it and say just do it, except maybe in certain conditions where we may not be able to go by the recommendation, by the evidence alone. Like for instance in COVID or in patients with pregnancy, we interpret other studies to make a recommendation in those states. In a weak recommendation, we want to know whether it will help us to make a shared decision along with the patient or the patient caregiver. So, as per the results of this guideline and the systematic review, there was an uncertain reduction in the mortality, which is 2% crossing the line of no significance, versus a mild increase in neuromuscular weakness. This is something that can be explained to patients easily, and it is possible to make a shared decision with the patient or caregiver in each individual case using this guideline. Was the influence of conflict of interest minimized? Like Sir said, this was done with BMJ and the MAGIC app. So they had done a pre-screening to look at the panelists, and they had judged that no panel member had any financial conflict of interest. But 3 panelists were part of the systematic review that was included in the guideline, and there was some sort of an intellectual conflict. So coming back to our patient, so as per this guideline was well done, and as per this guideline, there is a weak recommendation to give corticosteroids. We have to make a shared decision along with the patient and the relative. However, the study had excluded patients with known adrenal insufficiency prior to the systematic review, and the likelihood of somebody who comes to our hospital who may have some sort of apparent or evident adrenal insufficiency is quite high. So I would continue to give corticosteroids in septic shock and would not use this guideline to treat my patient. Just a brief this thing on agree to. Like Sir said, if we Google agree to, there is a manual that comes online where we can fill online and is very user friendly. So primarily it looks at 6 domains similar to the initial strategies of the WHO formulation of a guideline. It has got 23 questions and 2 questions where it asks you how confident were you at the end of the entire exercise. And each question is rated from 1 to 7. 1 if you strongly disagree with what was done, and 7 if you strongly agree with it. It will also tell you what the question means, where to look in the article to look for the answer, and how to rate it, how confident, which of these numbers you should be able to. I will just rush through the domains alone. So the first domain looks at the scoping and the purpose of the guidelines. The second domain looks at who the people were who were involved in making the guideline and who it was targeted to. The third one looks at how well they looked at the evidence and how the evidence was formulated, and whether they have mentioned any ways to update the recommendation once new evidence comes. The fourth one looks at how clear the recommendations were as part of the guideline. The fifth one looks at how implementable these recommendations are. And sixth one looks at conflicts of interest.